Morning, everybody. Thanks for coming. So this is the final talk in the medical series of this quarter. And we're very fortunate to have Emeritus Professor Mike James to talk to us on the history of anesthesia. I'm just going to give you a thumbnail of this man's, what he's done in his life. He's born and bred in Bulawayo. He has degrees from Birmingham, England, Wits. He's written over 200 peer-reviewed papers. That's a feather in your cap, I can tell you. He's been president of the South African Society of Anesthesiologists. He's been president of the College of Anesthesiologists of South Africa, founder member of SA Critical Care, previous professor, head of department of anesthesia, UCT. He is passionate about the English language, English literature, history, and sports of all types. He was a Rhodesian international hockey player in his time, and he was awarded Professor Emeritus from the University of Cape Town. So, Mike, we're really very pleased to have you. Greatly looking forward to your talk. Thank you.
Thanks, everybody. This is Human Rights Day. And it could be regarded that freedom from pain and surgery is indeed a human right. The importance of the discovery of anesthesia cannot be overstated. Anesthesia literally changed medicine in ways that had never been imagined. It can certainly be said that the most influential discovery in the entire canon of medicine has been that of anesthesia, certainly even greater than the antibiotic era. And to emphasize this point, I'm going to tell you a little story. I'm going to take you back 150 years to the Massachusetts General Hospital, to where a young man, Gilbert Abbott, was awaiting surgery. He was terrified. He was 20 years old, had a large tumor of the jaw, and was terrified of cancer, but equally afraid of the agony of surgery and the dreaded operating theatre. And it was called a theatre because that is what it was. This is the room today in which Gilbert Abbott had his operation. You can see it's set up as a theatre, but in Gilbert Abbott's day, it would have looked more like this. This is a theatre discovered in the roof, in the attic of Guy's Hospital in London, and a bear pit of horrifying proportions. You can see how the patients would have been focused on that wooden bench in the middle of the circle. People crowded around to watch the gory proceedings with mops and sand to collect the spilled blood and rough, coarse surgical instruments. A horrifying prospect indeed. But Abbott had been told that he could be a guinea pig for a new technique that might decrease the pain of surgery. And removing the pain of surgery had been an unattainable obsession among the medical fraternity for thousands of years. From the dawn of history, the pain of surgery was a problem to which there was no solution. Detigue, a French surgeon in the 18th century, said, "We should hear naught but an elemental roar of pain, uttered as with one voice by suffering mankind." Indeed, the only reported successful anesthesia and surgery comes from Genesis chapter 2, verse 21. The Lord God caused deep sleep to fall upon the man, and while he slept, took one of his ribs and closed up its place with flesh. So God was in the first instance an anesthetist. Others were less successful. Hippocrates forbade surgery to his trained physicians. "I will not use the knife, not even for sufferers from stone." There were many early attempts to provide surgical anesthesia, mainly composed of fanciful potions based on alcohol and opium and various additives. The Egyptians added in inhaled cannabis. Dioscores of Greece used mandragora root boiled in wine, and Galen also used this mixture, which was additionally used to ease the torment of crucifixion. Arnold of Villanova at the 13th century wrote, "To produce sleep so profound that the patient may be cut and will feel nothing, as though he were dead, take of opium, mandragora bark, and henbane root in equal parts, pound them together and mix with water. When you want to sew or cut a man, dip a rag in this and put it to his forehead and nostrils. Obviously, only the nostrils would have mattered. He will soon sleep so deeply that you may do what you will. To wake him up, dip the rag in strong vinegar. Simple. But even Shakespeare knew that this didn't work. Not opium, nor mandragora, nor the drowsy syrups of the world shall ever medicine thee to that sweet sleep. So the only real options were brute force or alcohol and opium, often applied liberally to both patient and performers. This painting from the 17th century dramatically indicates the horrors of surgery, with the man having his leg amputated, held down to restrain his agonies by various assistants of the surgeon, with his arm around the leg and the scythe-shaped knife ready to slice through the flesh. As Thomas Hobbes said, it was nasty, brutish, and short. The first glimmers of optimism came with Arnold Mesmer, who introduced what he called animal magnetism, later named hypnotism, which had some success, but it depended entirely on the patient's susceptibility, and very few patients could successfully stomach surgery with this procedure. The French surgeon Alfred Armand Louis-Marie Valpert was skeptical. The escape from pain in surgical operations is a chimera. Knife and pain and surgery are words which are always inseparable in the minds of patients. In the Far East, many attempts had been made. The Japanese and Chinese used a complex mixture of herbs called susensan, and Hanaoka, a surgeon in Japan, performed numerous procedures with this a remarkable potion, and he documented the first operations with what could be today called general anesthesia, though how successful it was is not actually recorded. But it was a mixture of a variety of what would now be regarded as pretty poisonous medicines. Nevertheless, Hanaoka was successful with this and performed 156 breast and other surgeries. But there appear to be of no successors who could apply this with his skill and success. The first real player in our history is this man, Joseph Priestley, a remarkable cleric and amateur scientist who experimented in chemistry, physics, and electricity, and isolated a variety of gases, and he was famed as the leading in pneumatic or gas chemistry in Europe. He discovered a number of gases, as you can see on the slide, including what he called dephlogisticated air, later equally erroneously, by the way, named oxygen by Antoine Lavoisier. He also discovered what he called dephlogisticated nitrous air, what we know of today as nitrous oxide, but no use was made of this until this fellow came along, Humphrey Davy. He was superintendent of Thomas Beddoes' Pneumatic Institute for the treatment of tuberculosis by the inhalation of gases. He experimented with nitrous oxide on himself and found the delights of inhaling this gas. He found it extremely pleasant, and indeed for a while became addicted to it. And he suggested that nitrous oxide could be used for the relief of pain in surgery, but never actually attempted it himself. He famously labeled it laughing gas because of its pleasant, intoxicating effects. And these pleasant and intoxicating effects led to it becoming popular in fairgrounds, where either willing or unwilling volunteers were given this gas to breathe and then staggered around in a drunken stupor. It was often noted that they injured themselves in their wanderings about, but the injuries did not appear to be painful. Another substance that was also used is a much older chemical called ether, which was also used in these frolics, but this goes back a very long time. A man called Raymond Lilly in the 13th century produced what he called sweet vitriol from sulfuric acid and ethanol. This famous fellow, Paracelsus, in many ways regarded as the father of modern pharmacology, who made the statement that all things are poisons and only dosage makes the thing safe. With his sweet vitriol, he said, it has associated with it such sweetness that it is taken even by chickens who fall asleep from it for a while, but awaken later without harm. He suggested it could be used to treat pain, but nobody thought of applying it to humans. Extraordinary. It was rediscovered by Valerius Cordus in 1550, and then Frobenius in 1729 gave it its definitive name of ether. It was used to treat respiratory ailments, but never thought of for surgical procedures. Our scene now shifts to America, where a young dentist called Horace Wells had been to one of these nitrous oxide frolics and noted the absence of pain in people who injured themselves. Being a dentist, concerned with the pain of dental procedures, and tried nitrous oxide inhalation on himself for the removal of a tooth. He was so impressed that he went to the Massachusetts General Hospital, approached the famous John Warren, the leading surgeon of his day, who did as many as 100 operations a year, a real frontline performer, and offered to do a demonstration. Sadly for Wells, he chose a large burly sailor as his first subject, and during the procedure, the sailor cried out in pain. Warren branded Wells a humbug. He was hounded out of the medical profession and later committed suicide. So there are dangers to being a failed anaesthetist. So let's go back now to our story of Gilbert Abbott. The next day, the 16th of October, 1846, Gilbert Abbott is brought into the dreaded operating theatre with the surgeon, the same one, John Warren, who had assembled helpers and students and other spectators, some notable people whose names we shall mention in a moment. And they were waiting for the arrival of this man, another dentist, William Thomas Green Morton, who'd been present when Wells had failed in his experiment. And he thought that Wells was onto something and experimented with various other compounds, including ether for dentistry. He tried ether on himself and colleagues and was so impressed that he persuaded the writer and surgeon Henry Bigelow to get John Warren to agree to another demonstration at the Massachusetts General Hospital. The skeptical Warren took a lot of persuading. He was manufacturing his own device to deliver the ether fumes, and that was why he was late. And this is the device that he had perfected, a model of which is now held at the Hrudisky's Excellent History of Anaesthesia Museum, and was presented to the department by the Wood Museum in Boston. Arrayed medical dignitaries would have met Morton when he walked in the seats in front of him. As he looked up, he would have seen what is now famed as the ether dome, the structure designed to let maximum light into the operating table with a reflective ceiling to maximize the visual. There's a seat labeled that was reserved for Morton and carries this plaque in the present day refurbished theatre. Warren scathingly said, "Your patient is waiting." Calmly, Morton walked up to Gilbert Abbott, put his inhaler to his mouth and told Abbott to breathe deeply. After a few minutes, Abbott appeared to be asleep. Unfazed, Morton turns to Warren and says, "Sir, your patient is waiting." In dramatic fashion, Warren seized his scalpel. His assistants held the patient down, while Warren, in typical fashion, made a rapid incision into the neck. And the most extraordinary event took place. Nothing happened. Abbott did not move or scream. He said later he felt no pain, although he started to move and moan towards the end of the procedure. Warren turned to the assembled company and said, "Gentlemen," there were no ladies present, of course, "this is no humbug." The physician writer Oliver Wendell Holmes, subsequently describing these events, coined the term anesthesia. And another attendee, Henry Bigelow, wrote, "I have seen something that will make its way around the world." That prophecy was to come true faster than Bigelow could ever have imagined. This was the days of sailing ships, no internet then, and news traveled slowly. But by the 15th of December, the first ether anesthesia was attempted in Paris for cancer of the lower lip, but it was a failure, probably because of poor quality equipment. On the 19th of December in London, a dentist, James Robinson, did a tooth extraction under ether and was so impressed he called his friend, the surgeon Robert Liston. They did another extraction together, and Liston thought, "This is fantastic." He had a young man, a Frederick Churchill, who's variously described as a butler or a coachman who desperately needed a leg amputation, but was too terrified to undergo the surgery. Robert Liston and a student whose father was a pharmacist, William Squire, they experimented over the weekend. This dental extraction had happened on a Saturday, and they spent the weekend trying to devise a suitable device to administer the ether vapor, and came up with something that seemed to work. So on the following day, Monday, the 21st of December, Liston, in typical showman fashion, assembled the good and the powerful of London's medical society into his operating theatre and brought Frederick Churchill terrified into the room. Squire administered the ether from a homemade apparatus. Liston seized the man's leg, took up his scythe-like knife, and in his famed way said, "Time me, gentlemen," and slashed through the leg, sawed through the bone, and removed the leg in 28 seconds, with no sign of pain from the patient. Liston turned to the crowd and said, "Gentlemen, this Yankee dodge beats mesmerism hollow." The era of painless surgery had arrived. It was to travel rapidly around the world. By April of 1847, the first dental extraction under ether was performed in Cape Town. And in Launceston, Tasmania, as far away as you can get pretty much, the first major anesthetic was performed in this hospital here. And there is a plaque on the wall over there which says, to commemorate the first use in Australia of anesthetics by Dr. R.W. Pugh on the 7th of June, 1847. A few days later in Grahamstown, the local general practitioner, William Atherstone, had a patient who was the local sheriff, Mr. F. Carlyle, who had been rolled over by his horse and had his leg seriously broken and was now going gangrenous. He too was terrified of the amputation. That Atherstone was an intelligent and well-read man and had read about ether and was determined to try it. Incidentally, he was a remarkable man and an amateur gemologist. And it was he who identified the very first diamond that triggered the Kimberley rush. Atherstone applied ether to the terrified sheriff and then amputated the leg without pain. When Carlyle woke up, according to Atherstone's later report, he said, "What? My leg is off. Impossible. I can't believe it." God be praised. It is the greatest discovery ever made. And indeed it was. Prior to anesthesia, surgery was barbaric and little surgery was possible. All of the advances in modern surgery have depended entirely on anesthesia and its process. To commemorate this, Henry Bigelow wrote of Morton, inventor and revealer of anesthetic inhalation, before whom in all time surgery was agony, by whom pain in surgery was averted and annulled, since whom science has control of pain. But in fact, Morton was not the first. That honor belongs to a humble GP in Athens in Georgia in the south, who had learned about ether at fairground frolics, as had the others. He had carefully documented 8 cases in which he had tried ether anesthesia successfully for relatively minor surgery, doing his first case 4 years before Morton in 1842. But because he was a careful, meticulous, and highly principled man, he did not publish his work until 1849. So Morton, for all his failures as a human being, gets the credit. Surprisingly, very few doctors in America took to anesthesia for reasons that are not explained. The difference was dramatic in the UK. Physicians immediately took an interest, including one of their most respected members, John Snow, who was already an established clinician in Soho with a very good reputation as a careful diagnostician and scientist. He invented his own ether inhaler in 1847 after seeing the first demonstration. He was present at Liston's operation on Churchill. He described 5 stages or degrees of anesthesia, which are still used to some degree today. he successfully used chloroform, a very difficult agent to use, and invented a calibrated inhaler so that he could control the dose. And incidentally, some years after this, in 1853, he took an interest in epidemiology, and he discovered a cholera epidemic that had broken out in nearby environs of Soho in Broad Street. Identified the water from the Broad Street pump as being the source of the epidemic, removed the handle from the pump, and ended the epidemic. He was the first person to demonstrate that cholera was a waterborne disease, and that added to his already considerable fame. He didn't get a knighthood, surprisingly enough, probably because he died young, but he got the second best for an Englishman, and that is he had a pub named after him. The John Snow pub, which is astonishing for a man who was a teetotaler all his life, is built in Broadwick Street in Soho, the new name of Broad Street, next to the site where the pump had stood, and it commemorates both his achievements in anesthesia and in epidemiology. Up in the north in Edinburgh, the youngest ever professor of obstetrics, James Young Simpson, young as an appellation to designate his youth, wrote that all pain is per se, and especially in excess, destructive and ultimately fatal in its nature. He was looking for ways of controlling obstetric pain, and he introduced chloroform in 1847, and he discovered this having been experimenting with various chemicals at a dinner party in his home, where they inhaled chloroform and they all passed out. Astonishingly, all his guests survived, perhaps as well for the story of chloroform. He claimed it had many advantages over ether, including its rapid onset, that you needed much less, and it was more comfortable to breathe. And he pioneered the concept of pain relief in labor. But this drew the ire of some members of the clergy, because the next chapter of Genesis, after the anesthetic incident, says to the woman, when they're being thrown out of the Garden of Eden, in sorrow shall thou bring forth children. It was therefore held that it was litigiously unacceptable to provide pain relief in labor. Of course, these were all male clergymen who made these statements, but this was to be put to rest once and for all. Snow's fame had spread, and Queen Victoria had heard of him, and she begged her physicians to ask John Snow to help her with the birth of her 8th child, Prince Leopold, because her previous pregnancies had been so painful. One can hardly imagine a more respectable occasion. There was Victoria, the image of Victorian rectitude. The anaesthetist was Snow and the nurse was Lily White. More propitious environments can hardly be expected. It was a magnificent success. Victoria referred to it as the blessed chloroform, and anesthesia and obstetrics became an accepted practice. Snow's great pupil, Joseph Clover, followed his work and was the leading anesthetic investigator. He developed ways of administering chloroform more accurately than dripping it onto a handkerchief, which was regarded as very unsafe by this time. He developed the jaw thrust, lifting the chin to clear the airway, because it was becoming patent to anesthetists that obstruction of the airway during anesthesia was a major cause of risk. He invented monitoring the pulse, and in his entire career, he had just one death. Remarkable for those days. But there were, in fact, many deaths, and this led to doubts about the validity of anesthesia. The first recorded death is on the 28th of January, 1848, a little over a year after the first English demonstration. This was a 15-year-old girl, Hannah Greener, who had had one ingrowing toenail excised under ether a few months earlier, and this time they decided to use chloroform. Within a few minutes of applying the chloroform on a handkerchief to her face, she dropped dead. This records in the parish register her burial record, and her death has been controversial, but it is still regarded as probably due to the failure of the heart rhythms due to the inhalation of chloroform, which is a potentially very dangerous anesthetic. But there were doubts as to the benefits of anesthesia itself. This surgeon, Henry Ward Beecher, said the stimulant effect of pain is essential for the success of surgery, similar to the other canard of laudable pus that surgeons were propagating at that time. He said the less pain, the less life capacity, the less pain power, the less life power. Pain was an essential constituent of the patient surviving the surgery. The New Orleans Medical Journal in 1847 thundered that mesmerism has done 1,000 times greater wonders. And one cynic, attributed to George Bernard Shaw, but I've never been able to track it down, said that anesthesia is not a blessing to mankind, but a curse, as it has enabled any old fool to become a surgeon, and they do. By the time of the Crimean War, the British Army were opposed to the use of anesthesia. Sir John Hall, the chief medical officer in the Crimea, of course, so prominent in today's news, was hostile to the use of anesthesia. He warned his medical officers against chloroform, even for treating severe gunshot wounds, saying, however barbarous it may appear, the smart of the knife is a powerful stimulant. It is better to hear a man bawl lustily than see him sink silently into the grave. The British Army discouraged anesthesia as too dangerous, but that was rapidly outdated. By the time of the American Civil War, just a few years later, anesthesia had become established, together with opium pills and the use of morphine that were used extensively on both sides. The famous Southern General Stonewall Jackson had his leg shot off with a cannonball and had chloroform for a limb amputation. Sadly, he died a few days later from pneumonia, possibly due to inhalation during the anesthesia. Morton played a prominent role, giving anesthesia to many soldiers of both sides. And chloroform was much more popular than ether because it was faster acting, less initial excitement in the patient, and it didn't catch fire. By the Boer War, the British had changed their attitudes completely. British medical services had 10 pounds of chloroform and 5 pounds of ether at every base hospital during the war, and their mounted doctors carried a bottle of chloroform in their saddlebags. The Surgeon General stated that the proper anesthetic for the field and the only one available in hot climates is chloroform. Anesthesia, though, was still a very high-risk business, and patients were dying from the effects of anesthesia. And consequently, people looked for other techniques. Regional anesthesia was introduced following the discovery of local anesthesia by Carl Koller, a pupil of Sigmund Freud, and the two of them had been playing around with cocaine for various purposes when Koller splashed some in his eye and found that his eye went numb. He then introduced cocaine routinely for eye surgery. The American neurosurgeon Halsted started to use cocaine to inject nerves and provide regional pain relief for local surgery. Sadly, he became a cocaine and morphine addict. Heinrich Braun, another German, pioneered regional anesthesia with a derivative of cocaine called procaine. And Augustus Karl Beer performed the first spinal anesthetic using procaine. He also pioneered intravenous regional anesthetics, and to this day, the famous Beer's block bears his name. That's a technique that many of you may have undergone, where they exsanguinate the blood from the limb, having put a cannula in a vein first, put it under tourniquet, and fill the limb up with local anesthesia, rendering the arm entirely numb. But airway problems remained a major anesthetic challenge, and this was emphasized by the famous situation of Edward VII, the son of Queen Victoria. He had delayed his coronation for a year in order to honor his mother, and he had put an enormous amount of expense and energy into arranging his coronation, but he was getting progressively sicker. He was determined to attend this coronation, to which his surgeon said, "Your Highness, you may attend your coronation, but you will only go as a corpse." His surgeon, Sir Patrick Trevors, then operated on his appendix abscess with the anaesthetist, Sir Frederick Hewitt. The anesthetic was a nightmare. If you look at the picture here, any anaesthetist would recognize that this man is an airway problem waiting to happen. Short, fat, neck, thick, set, obese man with a full beard. Everything a skilled anaesthetist dreads. And certainly Hewitt battled to keep the king alive, keeping oxygen going in and out of his lungs, eventually resorting to lifting his chin by grabbing the beard and tugging on it. So despite the fairly nightmarish anesthetic, the king made a good recovery, but it emphasized the importance of airway problems. And this was brought even more into the forefront by World War I. People say that world wars are good for medicine because it drives inventiveness. And certainly this war created massive medical challenges. Blood transfusion came to the fore in this conflict, and the high incidence of head wounds resulting from trench warfare created massive airway problems for the anaesthetists. And consequently, they developed the management of airways by placing tubes into the windpipe, called endotracheal intubation, and advanced airway skills became mandatory. Better equipment was developed. Boyle developed the first gas delivery system for controlled administration of gases, and airway control was improved. The same Hewitt developed an airway that fitted in the mouth, and then Goodell produced his version of the airway that is still used today. Any of you who've had an anesthetic will have had one of these curved plastic devices placed in your mouth. The two leading anaesthetists in England at the day, McGill and Mackintosh, the first professor at Oxford, developed tracheal intubation to a high level of skill. But there were many problems remaining for anesthesia. There was no way of accurately measuring dosage. The devices used to administer the vapors could not be accurately controlled. There was no control of the depth of anesthesia. There was no meaningful monitoring, and deep anesthesia was required if the surgeon needed to get into the abdomen and relax the muscles of the abdominal wall. So the quest for safety led to the search for better controlled anesthetics using shorter acting agents, different drugs that didn't require inhalation that could be administered in more calibrated doses, and especially to get rid of chloroform that people were realizing was more and more dangerous. The idea of balanced anesthesia using multiple drugs to achieve the endpoint was becoming popular. Equipment was improving, but most of all, particularly after the Second World War, anesthesia training dramatically advanced to the point of highly professional training, the equivalent of any other medical specialty. The intravenous drugs came along when barbituric acid was first synthesized by Adolf Bayer in 1905. Veronal was introduced in 1907 for IV anesthesia, followed by hexabarbital, and then the astonishing thiopentone. Probably the safest, powerful medicine ever introduced into modern medicine. First used by Lundy in 1934 and was the gold standard for intravenous anesthesia for over 50 years. Probably the safest, powerful drug ever used in history, given to millions and millions of people with very few adverse effects. It nearly suffered a tragic demise at Pearl Harbor. After the bombing of the naval base, the American surgeons had not been trained in the use of thiopentone and gave far too much. It was reported erroneously, but nevertheless hit the headlines, that thiopentone had killed more American soldiers than the Japanese. Fortunately, Ralph Waters, the first professor of anesthesia in America, scotched that and restored thiopentone to its proper place. The problem of managing muscle relaxation was also solved in an unusual way. Originating from South American arrowhead poison, a substance called urari was introduced that apparently caused a peaceful and painless death. I can imagine nothing more terrifying than lying paralyzed while you suffocate slowly. was derived from Strychnos toxifera, a plant growing in South America, and curare was introduced to Europe by Walter Raleigh in 1595. Here it remained a curiosity and an occasional poison used in murders, but a squire called Charles Masterton, an amateur scientist of note, had noticed that in fact what it did was to stop breathing in animals. So he had an ass in which he injected curare and then ventilated the ass using a pair of fire bellows, keeping it alive for over 2 hours until the ass gradually recovered and walked away. A signal observation. What the ass thought about this is not recorded, but it triggered the famous French physiologist Claude Bernard to go into investigation of nerve muscle connections. It was thought at that time that the nerves provided an electrical stimulus directly to the muscle, but using curare, Bernard was able to show that it was a chemical link, and this provided the chemical basis for so many modern pharmacology advances. Harold Griffiths, the first president of the Canadian Society and the first president of the World Congress, introduced curare into anesthetic practice in 1942, and it had a dramatic effect. This allowed muscle relaxation at much safer levels of anesthesia, and it had a bidirectional impact on anesthetic mortality. Initially, because anesthetists didn't know how to manage the respiratory paralysis, there was a marked increase in mortality, but subsequently there was a dramatic drop in mortality as anesthetists learned how to use these new, very powerful medicines. And this is dramatically illustrated in this graphic from a South African study showing the impact of curare. Over here, you can see the time when curare was introduced, a doubling of anesthetic mortality, which was at that time sitting at 1 in 1,000 anesthetics. And then the rapid fall away over the next 25 years to much more acceptable levels of mortality. So anesthetic safety remained an obsession with anesthesia. In 1952, The Lancet, in an editorial, commented, "The most obvious risks of a surgical procedure are those associated with the anesthesia." Just 30 years later, the American journal Anesthesiology commented, "The most insidious hazard of anesthesia today is its apparent safety. That safety was not because anesthesia was safer, but because its practitioners had been properly trained and had developed greater skills." Anesthetic mortality was a major issue in the early 50s. The first studies suggested that the death rate from anesthesia was greater than 1 in every 1,000 anesthetics. Now, just to put that in perspective, if that was still the case today, anesthesia in South Africa would be responsible for more deaths than taxi drivers. The introduction of curare resulted in a fall over time in mortality by over 35%, allowing lighter airway, lighter anesthesia, and better management of the breathing pathways. Newer volatile anesthetics were introduced to replace ether and chloroform, halothane, enflurane, isoflurane, and then the modern two, sevoflurane and desflurane, which have not been vetted for 30 years. These allow faster onset and shorter duration of action than ether, and they're not inflammable as ether is, and they're very much safer than chloroform. Intravenous drugs came along. This astonishing molecule, diisopropylphenol, was developed by ICI in 1977, but it was not water soluble, so injecting it was a major problem. And eventually, ICI chemists, in a brilliant piece of chemistry, formulated it in an emulsion of soybean oil and launched this in 1986 with the trade name of Diprovan. It is currently the #1 intravenous anesthetic and has been for nearly 40 years and is slightingly referred to as the milk of amnesia because of its pure white color. Monitoring became a critical part of anesthetic safety. Intraoperative blood pressure monitoring was never used for the first 60 years of anesthesia until suggested by the American neurosurgeon Cushing. ECG monitoring is a very modern invention. When I started anesthesia in the 70s, we didn't have an ECG monitor in the theater. Invasive and non-invasive dynamic cardiovascular measurement allowed us to titrate anesthetic dosage to physiological responses. Things that could measure the level of oxygen, like pulse oximeter, gas analyzers, so that we could actually accurately measure the dose of anesthetic being given. Echocardiography and the measurement of cerebral function have all contributed to the advance of anesthetic safety. And all of this was the subject of a remarkable 30-year study, unique in the world literature, by Gaisford Harrison, my predecessor at Hood's-Gear, who studied 30 years of anesthetic mortality. And as you can see on this chart here, anesthetic mortality sitting over here at around 1 in 1,000 deaths in the early 50s and 60s, dropping right down to this 4 times lower number here, despite a massive increase in the number of operations and anesthetics and increasing of the severity. And this advance in safety allowed for that extraordinary event, the first heart transplant. Now, Christian Barnard, of course, and correctly gets the enormous credit for having the courage and skill to do this first procedure. But what has been forgotten is that the real hero was the man in the middle of this picture here, Joseph Osinski. He was the anesthetist, and his assistant was Cecil Moss, there on his right-hand side here, who was a famed Springbok winger and also subsequently a Springbok rugby coach. The third person in this is Professor Arthur Bull, the then head of department. Without the advance of anesthetic skill, the transplant would have been impossible. Washkansky was a dying man. He could not breathe lying flat in bed. He was at death's door. The edema from his heart failure had so filled his legs that they had to put drains into his legs to remove the excess accumulated fluid. Yet Osinski had the skill to keep this man alive for 8 hours using the simplest of medicines as we might regard it today. He started the anesthetic just after midnight on the 3rd of December and kept Washkansky alive for 8 hours until he was able to take him to the intensive care unit. And here, Oz managed him in ICU until he died 18 days later. A brilliant man, but self-effacing, he never sought the glory that he really ought to have received. When it comes to safety, anesthesia has made the most spectacular improvements in safety of any of the medical specialties. Mortality has fallen more than 200 times. 1 in 350 to a level that is today unmeasurable. It is such a rare event. It is at least, in the best of hands, less than 1 in 100,000 anesthetics. And this safety is not the result of safer drugs. All anesthetics are poisons. It is the result of high quality training, some better medicines, and particularly improvements in equipment. Anesthesia has gone from devices like this to the famed Schimmelbusch mask, which some of you may remember. I certainly was anesthetized with one of these when I had my tonsillectomy in 1953, and I was trained to use this device, difficult though it is, to the modern space-age technology of these kinds of machines which measure every physiological parameter conceivable and administer medicines in incredibly accurate doses. Today's anesthetist is far from a passer of gases. He is a perioperative physician, intraoperative physiologist and pharmacologist, and an expert in postoperative pain management. Anesthetists have played a leading role in the development of critical care, especially during the COVID epidemic. They are major players in pain therapy, and because of our expertise in pharmacology, we have played a significant role in the regulation of medicines, particularly in current times of this COVID epidemic. But most importantly, the anesthetist is the surgical patient's guardian between the patient and the grave. Of course, you don't adhere to modern scientific ideas. If you still are an anti-vaxxer or a believer in ivermectin, You can go for the older, cruder methods, but I wouldn't recommend it. Thank you for your attention. I'm happy to take any questions, comments, arguments, debates.
Actually, while I'm up here, I do have a question. Am I right or wrong? I thought that the ancient Greeks regularly used opium in operations. Was I wrong?
No, you're not wrong. It was one of the medicines that they used, but opium alone, completely insufficient as an anesthetic. If you want to use opium as an anesthetic, you have to give it in doses that will stop you breathing, which kind of counteracts the whole idea of keeping the patient alive.
Michael, thank you very much. I just want to tell the audience that Professor James received the Distinguished Teacher Award from UCT, and you can see why. Very, very capable and good teacher. Thank you, Mike. I had one comment, one question, a comment in one of my surgical textbooks. I remember there was a story about Liston, who you said did a 28-second amputation. And
Sure.
The story I have in mind, I don't know if that was his record, because I think he did even better than that. What I have in my memory is that he did an amputation of a leg. Now, this is the scalpel right around the leg, plus then sawing through the bone, and it had to be done at high speed, and it was very grim. But the record I have in mind was that it was 16 seconds, during which he amputated 3 fingers of the assistant holding the leg. The other thing, I wonder if you had a comment on Diprovan, milk of amnesia, and Michael Jackson for us. Do you have a...
Oh, yeah. Well, I guess that emphasizes my point that I made earlier, that anesthesia safety is a question of the training and skill of its practitioners and not the medicines. Anesthesia is the skilled administration of poison. And Michael Jackson was killed by propofol. I was in London on a sabbatical during the trial of his doctor, and a ludicrous defense was offered. And one of the leading American scientific anesthetists carefully demolished the arguments step by step. They'd even suggested that Jackson may have overdosed himself by drinking the stuff, which is ludicrous because the drug is eliminated through the liver immediately. So you swallow it and it goes straight out again. So it could only be given intravenously. And yes, overdose of any anesthetic will kill you. It's, as Paracelsus said 500 years ago, all things are poisons, only dosage makes a thing not a poison. And that is as true of salt and water as it is of arsenic and cyanide.
Thank you for the great talk. I was just wondering about consciousness in anesthetics. Nowadays, or probably for quite a long time, some patients are conscious of what's going on, or deliberately so. What is all that about?
Okay, so let's get philosophical about that. The greatest philosophical debate is, what is consciousness? I don't know. It's an extraordinary process of this couple of pounds of fatty tissue up here that synthesizes our inputs into what we call consciousness. Now, what we do in anesthesia, embarrassingly, having practiced it for over 50 years, is unknown. We don't know what we're doing. We know that patients become insensible to pain, but they still respond. Unless you massively overdose them, the blood pressure will still go up a little bit when the surgeon makes his incision. The heart rate will increase, and we need those kind of stimuli. And the problem becomes judging the level of consciousness against the patient's physiological well-being. And the introduction of muscle relaxants brought with it the terrible problem of a patient being paralyzed and awake. And there are nightmare stories that have discovered. Most of those have been due to anesthetic errors. People have forgotten to turn on the vaporizer to deliver the inhaled anesthetic, or they haven't injected the appropriate amount of drugs, and they've given patients relaxants. And there are some terrifying stories of patients undergoing procedures when they were wide awake. So there was a film, not a very good one, called Awake, in which a patient is awake during an operation. In fact, him himself a surgeon, and operating surgeon and other colleagues are discussing a plot to kill people with damage their brains and create organ donors. And so it becomes a thriller. I think it was a Michael Crichton. But it was based on the whole business that you can be conscious and awake during anesthesia if your anesthetist misses it. Good monitoring, being able to measure the depth of the volatile, the partial pressure being administered to the patient is your best guarantee that it can still happen. Extremely rarely now, but it has happened, and there have been famous and horrifying cases of this. So yes, it can happen, but usually it's a very rare event.
And so cooperation by the patient who's anesthetized is not really an option.
Well, you see, regional anesthesia has now become so widely used. Many patients are awake. So all obstetric anesthesia now, most cesarean sections, by far over 90% of them are performed under spinal anesthesia with the patient fully conscious, which is both to her benefit and to the baby's benefit. The mother can be there for the birth of her baby. It's a wonderful process. And so yes, in those circumstances, and there are other circumstances, the brain itself is not susceptible to pain, does not feel pain. It senses the pain from other organs, but it itself does not cause a pain sensation. And so consequently, during very delicate neurosurgical procedures, where it is necessary to stimulate bits of the brain so the neurosurgeon can tell what parts he can safely remove, requires us to wake the patient up in the middle of the operation. And a colleague of mine underwent just such a procedure. Under anesthesia, they did the craniotomy, they opened his skull, they exposed the brain, we filled him up with powerful analgesics, but we woke him up and we made him read things and recognize pictures while the surgeon mapped out the parts of the tumor he could remove without damaging the speech centers in particular. So yeah, there are all sorts of ways we play with consciousness, but by and large, I don't really know what we do.
Thank you.
I would like to thank Michael for an absolutely brilliant presentation. My story is not so much a question as a comment. I had the privilege of listening in on a Zoom presentation to an inaugural lecture at Anaesthesia, where the young professor who was recently promoted talked about his research on wildlife management and particularly the anesthetics involved in wildlife management, especially with regard to large animals, elephants, rhino, hippo, and many others that they use for tranquilizers and for the management of wildlife. And I could hear from the comments that were made that indeed we at Anaesthesia are probably leading the world in terms of anesthetics in wildlife and the complexities and how the technology has been absolutely amazing in the way they were able to save animals that previously we probably never heard about on the media, but that were lost because of the neglect and ignorance in terms of how to manage the anesthetic and the post-treatment. So just a comment, maybe Michael would like to add to that.
Yeah, they've got a wonderful, world-famous sort of veterinary anesthesia at Anaesthesia, and the developments, fentanyl, now famed in all of the detective stories as a drug of addiction and so on, is one of a family of drugs of which the most potent is carfentanil, of which nanogram doses will kill humans. And carfentanil can be injected by dots and is the most used, it was when I read it up, possibly been superseded more recently, but is the most used darting tranquilizer for elephants and rhinos and other big game. And the skills developed at Anaesthesia are really quite remarkable. They've got a very high reputation. They've published a lot of good work from animal anesthesia. And there's obviously a large overlap. There are unique aspects. Certain animals can't have certain anesthetics. Propofol, as I understand it, kills cats. Although it's the most widely used human intravenous anesthetic. So there are animal-specific issues that vets need to know about, and of which I am regrettably totally ignorant.
So very interesting that, in fact, my wife's currently watching a series on TV of, they have interesting murders on one of the channels, American Murders, and one of them currently going on is a fellow who they think shot his wife with a dart gun. He used to hunt deer to go and cut off their horns for some reason. And they think he shot her with a dart gun and then, you know, killed her after that. Bit of a grisly way to go.
Well, not really. I mean,
but it might have been like scopolamine, Mark. She might have been awake while he cut off her head, or no? Or,
that would be unpleasant. But if it was an opiate, she would be unconscious and very pleasantly drift off into a very pleasant stupor.
Thank you very much for that fantastic talk. Just a little aside. Many years ago, I was living in Gauteng or Joburg, and at Hartbeespoort Dam there was a snake pop. The owner, the one who ran, got bitten. I think it was by a mamba, and he quickly injected himself with something, and they carted him off and off to a hospital. And there he lay. He was conscious, but unconscious. While he was lying there, one doctor was talking to the other one and said, no, he's got a mamba, he's not going to live. And he lay there for 24 hours and slowly came right, and etc. And he said it was so terrifying to hear the doctor saying he's going to die. Let's not bother any further. Can you comment on that?
Oh yeah, I have an exactly similar incident. I was working in Harare Hospital in the intensive care unit when I got called down to the casualty department when a soldier had been brought in, bitten by a mamba. Now, there are a variety of snake toxins. The gaboon vipers are the most complex and do most things. Some of them, the puff adders, damage local tissue, which is why you get swelling and tissue damage, but don't generally kill adults. And then the viperidae, particularly the mambas and gaboons, carry a neurotoxin that paralyzes muscles just as effectively, in fact, more so than curare does. And their patients, their victims, die of paralysis. And I had this young soldier brought in, and I was asked to come down and confirm the diagnosis that this man was brain dead. He was still just about alive and had a heartbeat, but shouldn't we just write him off? And the moment I heard he'd been bitten by a snake, I said, absolutely not. Shoved an endotracheal tube into his windpipe, took him up to my ICU where I had to ventilate him for nearly a week, I think he took to recover. And he walked out of hospital completely intact. He didn't remember it because he had suffered a bit of hypoxia, which in his case was a mercy because his brain had shut down. It wasn't damaged, but it had shut down enough for him to lose consciousness. But yeah, mamba bites are one of the most potent neurotoxins and cause neuromuscular paralysis, so you can't move, very like curare. Same sort of action at the motor end plate, paralyzing the chemical connection between the nerves and the muscles, so you can't breathe. Frightening. And I'm completely aware of the kind of event that you describe as this guy having experienced. He would be awake, but unable to move or breathe. Terrifying.
Hi, Mike. It's just more of a comment than a question. I had my first general anesthetic at a rather similar age to yourself, with one of those nasty little ether things they put over your mouth and pour ether all over you. I then must have had at least another 10 general anesthetics for various things during the 50s. Everybody was completely anesthetic mad in those days. The dentist put me out to take a tooth out. I was put out to have some warts excised. I seem to spend every holiday one way or another being put under. These days, I mean, my children and grandchildren, I don't think have hardly ever had a general anesthetic. Can you comment on that? Thanks.
Yeah, keep out of the hands of doctors. Anesthesia, as I said earlier, is the skilled administration of poison and should not be undertaken lightly. The fact is that although anesthetic mortality now is way down at an unmeasurable level, these are poisons. Every single anesthetic drug used today has killed someone. Every single one. So avoid having, I've had a lot of things done when I had my denuding of my scalp as chemotherapy, and I had to have a long dwelling port put in. And I chose to have that under general anesthetic because it's easier for both the surgeon, the person putting in the port, and the anesthetist. But anything else I would have done under local if I could. Regional is much more logical and sensible. You don't want to poison your brain if you can avoid it. So far, we don't think that these chemicals do anything long-term on the brain, but there are some people who think maybe there's some hangover effects, especially in young children, where it may affect the developing brain. So that's a science that's still evolving. But by and large, anesthetics are incredibly safe, but you shouldn't take a chance. I do a lot of medical legal work, and there are lots of people still having problems with anesthesia. So don't have an anesthetic if you don't need one. The old joke when I was first at UCT was that if you were knocked down by a car and somebody came up to you and said, "I'm a medical student, I can help," you hoped he was from Stellenbosch and not from UCT, because UCT people could quote what was wrong with you, but Stellenbosch guys had much more practical training. To an extent, they led the way in skills laboratories. They set up a wonderful skills laboratory at Tygerberg before we did at Pritzker. And airway skills, managing airway skills on dummies is a much better way than teaching it on patients. So very good. That's a big advance. Of course, nowadays we've got all the fancy video optic skills, which allow you to see right down into the windpipe and the larynx and the trachea and so on. It's made it a whole lot safer. Again, better techniques, better skills.
Mike, I think we're going to wrap it up there. I want to thank you again for that very good talk. Thanks very much.